Bismillahirrahmanirrahim. So thank you very much once again. So what I will do in the next 15 minutes is to talk about the classification and ILD registry. So this is the task given by Professor Sohail Akhtar. I have no financial disclosures related to this presentation. So we'll talk about the classification. So ILD is very briefly family of many diseases. Classically been described more than 200 heterogeneous disease as far as the involvement of the lung parenchyma is concerned, either a combination or predominance of inflammation and fibrosis. The new term for ILD is diffuse parenchymal lung disease, because now we know it not only involves interstitium, but it also involves the alveoli and other parts of the lung parenchyma. They share similar symptomatology, physiology, and plain radiographic features. So as I told in my case presentation, that you have to be a good detective. So careful history, detailed history is extremely important, and there could be delays, So the patients come late to the clinic, the non-specific symptoms, poor perception of symptoms thought to be due to old age. Providers, it's a very important task to educate the general practitioners and internists that when to refer those patients to appropriate physicians and not to treat as congestive heart failure. Healthcare system, access to the healthcare. I'm glad that now we have a full hall, to learn about this so-called rare disease and the misdiagnosis. So they're all very common. So if we look into the history of progress of interstitial lung disease, as far as the classification is concerned, so the first description, official description, was by Sir William Osler in 1892, who described it as cirrhosis of the lung. Before that, there was a German physician who described a case report, followed by Hammond-Rich syndrome. So there was a clinician and pathologist, all of us know, is an acute interstitial pneumonia pattern, which was described in 1935. And then the first classification that came up was from two pathologists, Libo and Carrington, who described the classification of ILDs. Followed by Mueller and Colby, it was a radiopathological classification of disease. And finally, the ATS-ERS combined guidelines, which was published in 2000. So if you look historical classification, it was predominantly pathological, then combined pathological and radiological, and eventually the clinical, radiologic, and pathologic classification of particularly idiopathic interstitial pneumonitis. And these are the landmark papers and guidelines for disease classification, as I've already mentioned, the names of these gentlemen, and then 2000, and then it was updated in 2002, then in 2011, again, it was updated in 2013, and then in 2018 about idiopathic ones and the hypersensitivity pneumonitis. We have other speakers who are going to talk about it, so I will not go into the details. So other than the idiopathic varieties, other interstitial lung diseases, classification is also in evolution. This is the further dissection. So you can divide into known and unknown categories. Unknown category is divided into IPF and non-IPF. And non-IPF is further subdivided into 6 subcategories as shown over here in the relatively 2 new entities, unclassifiable and pleuropulmonary, pleuroparenchymal fibrolastosis, and the granulomatous DPLDs and other forms of DPLD, which other speakers are going to talk about it. So this is the evolution of IPF over the last 2 decades. As you can see, that since 2000, you have seen multiple updates of the classification and the diagnostic criteria. I was in ATS this year, and this is one of the slides was shown by Professor Ganesh Raghu, that is IPF a real diagnosis or it's a dying diagnosis? So everything, or I must say majority was IPF until, let's say, 10 or 15 years back. But now with the evolving criteria and the better criteria, idiopathic pulmonary fibrosis is now a less favorable, or you can say a dying diagnosis. So we still talk about IPF as an entity of unknown cause, which was developed in 2000 guidelines. But is this simply an entity of unknown cause, or it represents a manifestation of so-called honeycomb changes, which you saw in the CT scan shown by Professor Sohail Akhtar? Another entity which has come up in the last several years is what we called IPAF. I'm sure majority of you are familiar with it, but those of you who don't know, it stands for interstitial pneumonia with autoimmune features. These are the patients in which they do not qualify the criteria of underlying connective tissue disease by a rheumatologist or by the rheumatology guidelines, but they do have some taste of autoimmunity, which again, ERS and ATS combined statement. It was published in 2015. There were different names given to this entity, as you can read over here, but nowadays we call it IPAF. IPAF में जो criteria होता है उसको हम तीन उसमें divide करते हैं, clinical, serological and morphological. उसमें interstitial pneumonia by HRCT, exclusion of alternative diagnosis, no definite connective tissue disease, and at least one feature from two of the three domains. So if that turns out to be positive, you can label as IPAF. Hypersensitivity pneumonitis ki, I think Dr. Professor Musawwir Ansari is going to talk about it, but just to show you the classification, it has been updated again after 1989 to 2020, so I'm not going to talk about it. I thought I must share this picture with you. I just went to Malir Kent. जावेद भाई के घर नहीं गया था, बल्कि अपनी भाभी के घर गया था. तो वहां पे अस्करी 5 में, which is so called one of the neat and clean areas in Karachi, and I took this picture. तो आप ये देखिए कि कितना बड़ा ये रिस्क फैक्टर है. इसमें आपको कबूतर यहाँ पे नहीं नजर आ रहे, लेकिन उनका एक्सक्रीटा और फेदर नजर आ रहे हैं, और यहाँ पे कबूतरों ने बसेरा किया हुआ है. And this is one of the picture. Fortunately, we have a new pediatric ward over here. This is an AKU clinic. जहां पे मैं क्लिनिक करता था, उसका जो बैक डोर था, उसकी ये पिक्चर है आज से 10 साल पहले की. सो दीज वाइल्ड पिजन्स आर जस्ट एवरीवेयर. फिर एक और नई डेफिनेशन जो क्लासिफिकेशन के हवाले से इस प्रोग्रेसिव पल्मोनरी फाइब्रोसिस पीपीएफ की आई है, और उसमें आई वोंट गो इनटू द डिटेल्स, बट इट हैज बीन डिस्क्राइब्ड बाय रघु एल ऑल कि उसमें अगर वर्सनिंग हो रही हो तो अगेन two of the three criteria. One is symptomatic, another is physiologic, and third one is the radiologic. You can Google and you can read in detail about it. Very quickly about the ILD registry, Dr. Musawwir Ansari is here. He is the pioneer of ILD recognition and starting the ILD registry, so we should give him a big applause for that, And he's the one who motivated me that we need more people in this field. So this is the advisory group. We met somewhere in 2016 in Islamabad, and we decided we have to do something. I started a dedicated ILD clinic. I took one of my junior colleague with me, but unfortunately he backed out. उसने कहा मैं तो सब कुछ देखूंगा, मैं तो pleural effusion भी देखूंगा, TB भी देखूंगा. मैंने कहा भाई देखो सब, लेकिन एक clinic dedicate कर दो तो कोई हरज नहीं है. तो खैर anyway, so this is the spectrum of ILD. इसमें मैं बस आपको एक चीज हाईलाइट करना चाह रहा हूं कि ये हमारा रेट्रोस्पेक्टिव डेटा है. उसमें जाहिर अपनी लिमिटेशंस के साथ it was number 3 and this is data is from 2007 to 2016. और फिर हमने जो अपना ILD का डेटा जो जमा किया, being the 4th most populous country in the world, जिसमें हमारे 16 सेंटर थे और बाद में 10 रह गए थे from 5 cities. This was presented in the annual CHEST meeting, oral presentation थी, and then we published in one of the good journals. इसमें आप देखिए CTD ILD जो है ये नंबर 4 फॉल कर रही है. सो टोटल 121 केसेस थे आउट ऑफ 750. व्हाट आई वांट टू हाईलाइट ओवर हियर इज कि बहुत सारे केसेस जिसको हम खास तौर पे इडियोपैथिक NSIP कहते हैं या IPF लेबल करते हैं और इवन HP लेबल करते हैं, as I showed you in my case as well, they eventually turn out to be CTD ILD. This is my own data which I just updated yesterday. And the scary thing in my data is that the CTD ILD is number 2, and I will not be surprised that in the next few months or a year, this will be the number 1 interstitial lung disease diagnosis that at least we are doing at our center. और उसमें अगर आप डिस्ट्रीब्यूशन देखें तो उसमें रूमेटॉइड आर्थराइटिस इज नंबर 1 एंड देन स्क्लेरोडर्मा, MCTD, ILD एंड देन सम अदर एंटिटीज व्हिच आर रिलेटिवली रेयर। और एक और एंटिटी जो हम सब ने 2020 के बाद देखी कोविड पेंडेमिक में इज कोविड ILD. So this is number 4. So I would like to finish my presentation that MDD is important and radiologist is a magician for us, you know. So a well-trained radiologist, yes sir, आपने भी कहा, is a blessing. क्योंकि वरना आप खुद ही रेडियोलॉजिस्ट होते हैं, खुद ही रूमेटोलॉजिस्ट होते हैं, पल्मोनोलॉजिस्ट तो होते ही हैं आप. So that is the end of my presentation. ILD is a group of complex disorders, but our understanding has evolved drastically. MDD collaboration is a standard of care, and please be a part of ILD registry. And don't worry about artificial intelligence. It is not going to replace human intelligence at all. Thank you very much for your time.